We would like to extend a warm welcome to all patients attending the Patients Today event. Today's topic is lung cancer. The treatment of lung carcinoma is a broad and evolving field for us to discuss today, in which diagnostics and therapy have developed rapidly in recent years. Every year, the ASCO takes place in Chicago, the largest and most important cancer congress for all indications, providing crucial impulses for everyday clinical practice. Current research findings on Professor Reinmuth, who attended the event in Chicago, will present the latest findings on lung cancer to us today in an understandable way. Professor Reinmuth is the chief physician at the Asklepios Lung Clinic in Gauting. He is with the Department of Thoracic Oncology and serves as the head of one of the largest lung tumor centers in Munich, Germany. He also teaches at Ludwig Maximilian University in Munich and is the author of numerous publications on various issues related to various different manifestations of lung cancer. And he also conducts studies himself or is actively involved in them. My name is Heike Gantke. I am a patient living with ALK positive lung cancer patient at stage 4, and I am on the board of zielGENau, a patient network for patients with mutation-driven lung cancer. As with patients today, one of our most important goals is to inform patients about therapy options so that they can competently participate in decisions about their treatment, because informed patients live longer. I am very pleased to now discuss selected studies with Professor Reinmuth. These developments could significantly influence the future of everyday treatment for lung cancer patients. We will begin our discussion by focusing on targeted therapies, starting with a detailed look at the Libretto 432 study. This is a phase 3 clinical trial designed for patients with non-small cell lung cancer and a specific RET fusion. In this specific clinical study, the efficacy of selpercatinib was rigorously tested against a placebo control group across stages 1B through 3. We are now honored to have Professor Reinmuth join us to discuss these findings. So, Professor, the floor is yours now to begin your presentation.
Yes, thank you very much, Ms. Gantke. The Libretto study was indeed one of the major highlights for us at ASCO. We know that patients with ALK or EGFR alterations after complete resection and possibly also after chemotherapy, which was somewhat optional in each case, they would undoubtedly derive a significant benefit from an additional targeted therapy, especially when it comes to the long-term clinical outcomes for the patients and the potential risk of the disease recurring back over time. However, the primary challenge we face is that these highly specific targeted alterations, these factors have already altered the nature of the tumor somewhat, and the risk that this tumor has already spread elsewhere is actually not insignificant. In other words, the tumor is becoming more aggressive. Accordingly, a subsequent targeted therapy for EGFR and ALK is associated with improvements regarding relapse, so to speak. And this has now also been investigated for RET fusions. That's why there was also a comparison with placebo, because all the patients underwent surgery, meaning the tumor was completely removed by the surgeon. They could have received chemotherapy, which most patients in this study actually did. And then there was either a targeted therapy with selpercatinib, which is also approved for stage 4 for 3 years, or placebo. Of course, first, the patients had to be tested for RET. This is a rare alteration, maybe 2% of tumors have this alteration, especially in non-squamous cell carcinoma patients. So it was a huge study worldwide, and in total, there were 75 patients included in the selpercatinib arm and 76 patients in the placebo arm who continued treatment for 3 years after surgery and possibly after chemotherapy as well. And now they looked at event-free survival, meaning basically until the tumor comes back, and all the other endpoints like overall survival and so on, those results aren't out yet. And they looked at this for the patients where the probability is highest that the tumor could come back. In stages 2 and 3A, and this is the result, you can see clear improvements with selpercatinib. Consequently, this specific course of therapy, which lasts for 3 years, has been shown to effectively prevent, compared to a placebo, not completely, but relatively speaking, the tumor from coming back. Hazard ratio 0.172. This is comparable to what we see with EGFR and ALK. But of course, it also means that we have to take this medication for a full 3 years. Overall survival has not been determined. It is something we do not know yet. Whether it improves survival, we can't say that taking the medication beforehand makes sense because it wouldn't work afterwards, since it still works then. Patients can also take this medication only after a relapse. But as I said, these data are available, not yet. We always worry that patients who end up in the placebo arm might not receive selpercatinib later on, because by then their condition might already be too poor. So we don't know that either. And whether stage 1B actually benefits as much compared to 2A or 3A, we also don't know yet, because the curves are only available for these pooled analyses. 2 to 3A and 1B to 3A. Why are there these differences? Because that was specified in the study protocol. That's what we want to analyze. Everything else isn't really analyzed in detail. They just take a look like here as well. And of course, we see elevated liver values, sometimes a few cases of edema. So we really don't have any new aspects. This is a medication that overall can be used quite well. But it's also not the case that the patient doesn't notice at all for 3 years that they're taking a medication. Overall, it's doable, no question. So very good data. We should definitely test patients for RET. So test for RET and then also advise them whether they can receive this therapy. But of course, it first has to be approved in Germany.
Well, it really does sound incredibly promising and exciting. It's actually very much comparable in nature to the situations we see with ALK and EGFR. For me personally, it was actually the case that the 4 cycles of chemotherapy I underwent after my surgery in stage 1B very quickly showed no real effect anymore. And then it was only at the point of progression that the ALK-TKI was finally administered. Of course, it is quite difficult, I think, for patients to decide for themselves, as you said, should I now take this path, take a medication for several years, or am I done within 3 months after 4 cycles of chemo? And then maybe it's behind me, yes, even with all the side effects that occur. What is your assessment? How will patients who are faced with this decision?
I think you said the most important thing right at the beginning. We need to test patients. So far, we have only done broad molecular testing in stage 4, where you say you can't do local therapy. And we're learning more and more, especially with studies like these. We need to test broadly because the tumor has a certain potential to spread, and right from the very beginning. And ideally, we need to learn as much as possible about the tumor, meaning broad molecular testing should be done right from the start. But currently, the costs for this are not covered because people say, well, it matters if we know the patient has a specific mutation. There's no approval. So what's the goal? They're right. Yet I believe development is moving toward testing patients early and comprehensively. Then we can discuss the next steps. We have a patient who has a RET mutation and is currently receiving adjuvant chemotherapy. I think that should definitely be carried out because possibly independent of the targeted therapy, the chemotherapy may also provide an additional benefit. And then we'll submit an application for cost coverage and are curious to see what the insurance company will say.
So this means we as a patient network are also called upon to raise our voices once again and to clearly state that patients benefit significantly from this approach. There is corresponding data currently available to support this, and we ask that you please make sure that this testing becomes part of routine clinical practice.
I agree. In fact, testing is just as crucial as the therapy itself, no question about it. But without testing, you won't even have a discussion about therapy. And whether the patient then says, I want this therapy, or says, no, I'd rather not have it, that can then be decided on an individual basis. But patients need to be properly advised. And the data really is impressive, you have to say, even though, as mentioned, we still don't have any data on overall survival and therefore can't say with absolute certainty that this therapy given for 3 years not only prevents the tumor from coming back, but also improves overall survival. But we must not forget the surgery itself already cures a certain number of patients, probably at least 50%. So that's already, these patients are in any case being treated unnecessarily because, of course, surgery alone already cures some patients. And that's something we have to accept as well. We're only treating a risk here. We're not treating a visible tumor.
I have to say, it was actually my good fortune at the time that I was tested, even though I was only at stage 1B. and it was determined very early on that it was an ALK fusion, so that when the disease progressed so rapidly, they were able to react immediately with another round of testing.
A very important point.
And regarding the specific application for cost coverage that you previously mentioned, is then submitted by the treating physician.
Yes, a very important point.
Okay, good. So that means the patient doesn't have to take care of that themselves in this case. But yes, how does the patient get their doctor to have them tested? Do they have to? I mean, we always say when it comes to lung cancer to contact the appropriate certified centers. Ideally, we use the National Network for Genomic Medicine because they are simply well equipped and prepared for this, especially when it comes to testing. How do you ensure that patients are directed into the correct clinical channels? Or rather, how do you inform general practitioners about how important it is in these cases to guide patients into the right pathways?
In my opinion, the best thing is that he should turn to a certified lung cancer center. Their expertise is available, and it is routinely checked whether the expertise is actually applied and whether the quality is right. That's the best we have. It's a great system. Of course, this testing for RDT still has to be introduced in Germany. It's not yet included in any of the recommendations because the study has only just come out. But I think that will happen, and we will have to conduct testing. And there will also have to be discussions with the health insurance providers. But there are definitely certain organizations who will handle this. And I am optimistic about that. But the most effective and recommended approach is for the patient to carefully select a treating physician who has the appropriate expertise. And if that means having to drive 30 kilometers further, then that just means driving 30 kilometers further. That's how it is. I mean, I don't have a Porsche, but if I did have a Porsche, I wouldn't just take it to any garage, but preferably to one that actually knows about that kind of car.
Yes, that is true. And I personally believe that if it actually comes down to a TKI, for example, then it's also the case that I don't have to visit the clinic nearly as frequently as before, and then visit my center as often in everyday treatment.
Yes, that's true. He just needs to be involved. In fact, a lot can actually be continued locally, which is absolutely right.
That is exactly right. Okay, then let us now proceed to the next study on targeted therapies. This is the FLAME clinical trial is a phase 2 study for patients with non-small cell lung cancer who harbor an EGFR mutation, such as the exon 19 deletion or the L858R substitution, when the tumor is locally advanced or is metastatic. In this research, they evaluated the efficacy of osimertinib plus chemotherapy compared versus osimertinib alone.
When I saw this study, I was really excited. It's a glimpse into the future. A Chinese study. They put in an incredible amount of effort. And the thing is, there are patients with the EGFR mutation who are treated with chemotherapy and osimertinib or with just osimertinib alone. Both are approved. Generally, osimertinib is considered the standard, then standard chemotherapy. And this is particularly relevant for patients who still have detectable tumor DNA in their blood after osimertinib therapy. That's something we currently do not test for in practice. There are many studies that have investigated this retrospectively, but not yet prospectively. And this study has now looked at it. Patients are treated with osimertinib, and for all patients, for those patients who still had circulating tumor DNA in their blood after 3 months, that is tumor debris, as one might say, they then investigated the question of whether osimertinib alone or in combination with chemotherapy is actually more effective in this case. Pretty impressive. Such a study would take a very long time in Europe. The Chinese simply managed to get it done quite efficiently, and that's exactly what they looked at. Of course, it's not a huge study because many patients no longer have any tumor DNA after 3 weeks of osimertinib. But here, 80 patients in whom this was still the case were examined, and they already showed that the combination with chemotherapy is much better than osimertinib alone. So what does that mean for us? Unfortunately, nothing for now because we don't test for ctDNA. So nothing. Secondly, we actually use chemotherapy together with osimertinib more often from the start than osimertinib alone. There is also a third option with an antibody called amivantamab and lazertinib. So those are the 3 options for EGFR mutations. And actually, in my opinion, the question is being asked the wrong way around. because in Germany we conducted a study with what is actually the right, in my opinion, the right research question, but even there, only a few patients, because it is a rare. Regarding this event, the core idea we are exploring is, can we achieve even better results with osimertinib monotherapy? Then we could simply stick with osimertinib alone, and we would not have to add chemotherapy. So we already knew that the combination is better than osimertinib alone. We didn't know that for this group, prospectively tested. That's what we've now found out here in the FLAME study. But retrospectively, yes. But it would have been more interesting before we give every patient osimertinib and chemo to say, no, we start with osimertinib. See if for those patients who no longer show any tumor DNA, we can simply skip the chemo. But unfortunately, this was not investigated in the study. But I believe we need the study because then we could spare many patients from chemo. The great thing about the study, nevertheless, is I'll leave out side effects because there was nothing new there. Of course, we already knew that chemotherapy causes side effects. But what's great is that these ctDNA measurements, which are not yet routine and will still take some time because it's not exactly trivial and it won't be cheap either, but we are capable of doing significantly more with them than with our traditional old tumor markers.
Yes, especially when we are talking about lung cancer, I personally think that the tumor marker isn't really that meaningful anyway, at least for certain specific types of lung cancer. Yes, I also experience it much more as a significant factor that often causes a great deal of uncertainty for some patients, because there can also be other reasons why the tumor marker increases. And so the fundamental question always is, when do you actually measure it, and what kind of practical sense does it truly make in the specific individual case at hand? What also consistently and deeply concerns patients again and again is the question, what about the reverse conclusion? Is it the case that the total absence of tumor in the blood completely and definitively means that the tumor is responding to the TKI?
If it was positive before, yes. If it wasn't positive before, we still don't really know what that means. Currently, we assume that this tumor doesn't spread so quickly in the broadest sense. So in a sense, we're treating a somewhat better tumor. But as you can see, we have these tumor mutations, we have these ctDNA measurements. Ultimately, we can gain a better understanding of what this tumor is actually doing there. Is it one that quickly releases tumor cells into the blood, which then break down there? And that's why tumor DNA remains? What is that anyway? That's why the ctDNA. I consider this to be an extremely exciting marker, and I hope that, well, I will hopefully still be around to see it, but that it will soon be anchored somewhere in tumor routine, that it will also be established. But it has to address a clinically relevant question. It can't just be for fun. It really has to say, okay, if I have this, then I can omit a medication, then I save costs, I avoid problems, quality of life improves. Or for example, I might give an additional medication because I realize, oh, I need to treat more. And for a longer time, this might be interesting for patients after surgery. So it's a marker with enormous potential. It first needs to be standardized. It needs to be shown that you can actually base a therapy decision on it, that you can, and that requires a lot of determination from the companies, but with strong resolve from doctors and patients to participate, plus a certain political motivation, so that it's not always just more, meaning 4 medications are not necessarily better than 3. 5 are not better than 4. 10 are not better than 2. But rather, no, can't we just sometimes leave out a few things?
Yes, I think that's a very important question, especially with regard to the side effects, which can vary greatly, varies quite significantly from patient to patient, and can have a profound impact on quality of life. So it's an important factor. The question, of course, is whether this procedure will eventually become a bit more affordable. It would certainly also be quite helpful if that were the case, so that it could be effectively
It first needs
utilized in
to be
practice.
available.
Exactly. Yes, indeed. I've also heard similar things from various other organizations and entities, that there is intense research being done in that area as well. When we consider the question of what exactly happens to ctDNA throughout the course of medical treatment, and yes, perhaps we can also gain valuable insights from studying other types of cancer in this regard.
No. So it's not that simple, the blood test, because you're not just looking for some 1 or 2 markers, you're looking at an entire panel of markers. So it's not exactly trivial. That probably also depends on the tumor itself, which panel you look at, but we're not there yet.
Okay, then let's take a look at the next study. This is the WU-CONG-28, a phase 3 study on advanced stage non-small cell lung cancer. We're returning our focus to EGFR gene mutations, but this time it's about the exon 20 insertion. And here they're testing sunvozertinib versus standard chemotherapy consisting of carboplatin and pemetrexed.
Exactly as the name suggests, it's also a Chinese study with a Chinese substance, zongertinib, a very specific tyrosine kinase inhibitor against these EGFR exon 20 mutations. And so far, there is nothing. As a TKI, we really have no effective options available. We have broad, general TKIs, but they lack the necessary specificity to work effectively against it. And the other therapy, the conventional standard of care chemotherapy, is actually standard chemotherapy with amivantamab with a bispecific antibody against EGFR and MET. That's actually the standard of care. And now, so to speak, zongertinib was tested against the wrong standard, namely only against chemotherapy. Still, it is interesting because it is an oral tablet and not administered through intravenous infusions. And it is a significant study that this was developed. Chemotherapy is given here up to 6 times, or alternatively, the daily tablet. And the primary endpoint was progression-free survival, so until disease progression. The secondary endpoints have not yet been successfully reached. The data wasn't quite mature enough yet for that. And we see that the median PFS was better than chemotherapy. The significant response rate was clearly better. And most patients in the chemotherapy group later received zongertinib. It's really great that they also did a crossover here. That's also fair to the patients. Unfortunately, that's no longer a given these days. There are also many reasons why that's no longer a given. But in this study, it was possible. That's why it's quite possible that overall survival isn't significantly better. So just the fact that we have a drug in this rather large study for these rare mutations that works well, that provides good, reliable data, that is better than chemotherapy alone, just that fact is already a great positive statement. Here, 2 studies are being conducted in Europe. We see that some patients had to discontinue treatment because of side effects, which are typical for EGFR mutations, like diarrhea, rash, and things like that. But overall, it's manageable. And all things considered, it's also quite all right. And if as a patient you have the choice during the chemotherapy sessions with amivantamab or a tablet-based therapy, then I can certainly imagine that some patients would prefer the oral tablet therapy because it's also more flexible and will choose it. That means the medication doesn't even have to be better than chemotherapy with amivantamab for me to consider it a real advancement. But of course, ideally, it should be tested against chemotherapy and amivantamab. That was not done here. That's why, well, despite that, the joy still outweighs it that such a medication exists. There are also other medications being developed in this area. Zongertinib is not the only one. The nice thing is that even for rare mutations, we are increasingly getting medication options. And that's great. And I'm happy when we will eventually be able to use this medication here as well. And as for the side effects, we have already established the fact that we can actually manage these cases quite well in a clinical setting. Of course, we are somewhat significantly spoiled by the highly effective third-generation TKIs against EGFR, which cause very few EGFR-mediated side effects. That has been significantly more here. But I do think that in individual cases, it will usually be manageable.
Well, as I have already mentioned earlier, for some individual patients, the side effects can be extremely difficult and quite burdensome. So at the end of the day, it really always depends on the specific individual case. You just can't predict who will react how strongly to such a tyrosine kinase inhibitor. But yes, this is exactly what we were all hoping for from this important medical event. Especially with the news that such innovative and potentially life-changing new medications are being presented and tested in clinical research studies. That gives us a profound sense of hope that things will continue to progress at a steady pace, despite the already incredibly rapid developments we have witnessed so far in this field. That progress is not coming to a complete standstill, but that there are constantly new and exciting developments for patients, especially those with less common genetic mutations. Now we come to the very next clinical study. This one is about asymptomatic brain metastases in non-small cell lung cancer, in this case with EGFR mutations. And regarding the ALK fusion positive group, the study examined immediate radiation plus standard therapy, consisting of a combination of TKI and chemotherapy, compared to brain radiation only during intracranial progression. This is a very exciting topic in current research.
We'll move into a kind of historical study in just a few moments, but that was also a great study. We know from previous generations of EGFR tyrosine kinase inhibitors that additional secondary mutations can often develop. Brain radiation for asymptomatic brain metastases was better for overall survival. Now, with the new TKIs, these third generation TKIs, there is much better intracerebral efficacy that is in the brain. That's why, as a rule, we forego brain radiation in cases of asymptomatic brain metastases, because it also causes side effects. And yet the question remains, might it still make sense, as with the so-called old medications, to add radiation? And this question was investigated in this study. So EGFR or ALK, since those are the most common, and of course the patient must also be appropriately fit. Asymptomatic brain metastases are very important here. If the metastases cause noticeable symptoms, that's a different matter altogether. And then either radiation was given immediately or only when the tumor in the brain began to get significantly worse, became worse. However, all patients were monitored with MRI every 3 months. And what was the result? Well, in terms of progression, it actually makes absolutely no difference at all. A very, very good and important answer: we can wait. When radiation was given in cases of progression, the extent of what needed to be irradiated was often greater compared to irradiating right at the beginning. Also, radiation in the brain already prevented further progression in the brain. This was also the case in the group that received radiation from the outset. But survival was the same, and accordingly, the survival rate was the same. And accordingly, I would certainly assume, in this particular case, in terms of overall survival, perhaps even a bit better in the arm where radiation is not given immediately. But you can't really say that. It was not significant. But of course, every radiation treatment also causes side effects somewhere, or can cause side effects, I would say. And therefore, we feel validated that for asymptomatic brain metastases, we should initially wait when using targeted therapy with EGFR and ALK and simply monitor for now. And we know these are the kinds of side effects. Radiation necrosis, nothing serious, but it does occur. In some patients, it can even be more severe. So when the tumor essentially breaks down and then causes an inflammatory reaction, that is what we call radiation necrosis. It can be just as nasty as the metastasis itself, but then not because of the tumor, but rather caused by the dead tissue. And accordingly, yes, targeted radiation is not completely trivial. And if you can wait, all the better. Nice study.
What I would be interested to know now, or what the patients listening right now might be interested in, is what exactly are these potential adverse side effects? Why is it actually the case that in some specific situations it might be better to exercise patience and wait initially? What specific effects am I actually protecting myself from with such cranial radiation treatments?
The first question is, does the tumor get worse if you don't irradiate? With these TKIs, you can generally say usually no. Actually, the effect is so good that you can really just wait at first. And only if a tumor does not respond to the therapy, which you find out quite quickly, then you can irradiate. That's how we are currently doing it as well. Of course, when you irradiate individual metastases, then this so-called radiation necrosis occurs. Why? Because you destroy this single thing with very high doses. And that can lead to an inflammatory reaction with headaches and so on and so forth. Fortunately, it's rare and usually not really highly relevant. It's different when you do whole brain irradiation, because there are many small metastases that are themselves asymptomatic. But with whole brain irradiation, there are indeed clear reports or findings that concentration ability can decrease, that the patient may not be able to read as well anymore, that you can't remember certain things as well anymore. And that is definitely a limitation. And when we talk about TKIs, and we'll get to a historical study in a moment, I'll probably touch on that topic again briefly. We're already talking about tumor control that can last for several years. And then such side effects, even if they are relatively mild, can still be quite bothersome for patients.
So, given the current situation in this case, you are actually suggesting that it is better for us to just wait for the time being.
Yes, but it really does depend on the metastasis itself, on the specific situation, and also on the tolerability of the medication therapy. With more experience, this also becomes easier than with less experience, to be quite honest. This needs to be discussed in the tumor board.
Therefore, as a patient with brain metastases, I should have a thorough discussion with my oncologist regarding which specific treatment approach he recommends to me and the reasons why he does so.
This actually applies to all patients with mutations because targeted therapies are not so simple today. It's not like you just say, I'll take this medication, and then if it stops working, I'll just take something else. Instead, there are so many strategies and so many new therapeutic approaches that you really need to be somewhat familiar with, because you already have to consider, what do I do, how, where, and when? Is it worth pushing through a therapy? Do I need to reduce the dose of the medication therapy? What impact does that have on my treatment, on my disease control, and so on? It's anything but easy. And the best example, which we'll get to in a moment, it is this truly historic study, the CROWN study. But I'd like to hand over the introduction to you again.
Yes, but you already mentioned it, the CROWN study. That is the specific study which was widely discussed and highly hyped 2 years ago at ASCO. People heard back then that there were actually standing ovations for the results that were presented there. It's about treating advanced ALK positive non-small cell lung cancer, advanced or metastatic, with or without brain metastases. And lorlatinib was directly compared as a first-line treatment against crizotinib.
Upon release, the third-generation TKI lorlatinib proved better than crizotinib, the first-generation TKI. So that's almost the weakest comparison arm you could have chosen. And at the time this study was published, alectinib or brigatinib had long been the standard. These two therapies have roughly similarly good efficacy. They were significantly better than crizotinib. That was the standard of care. They were very well tolerated. And lorlatinib was not tolerated quite as well. It does cause weight gain, lipid metabolism disorders, sometimes edema, and so on. So it's not such a pleasant medication. Sometimes even neurological problems and so on. And we said, well, it's better. We know it's a bit better right away, but is it really worth it? And then 2 years ago, this presentation came out. I think it was at ESMO, but I can't remember exactly. I believe it was ESMO. And it showed an incredible advantage compared to crizotinib, much more than what we know from alectinib and brigatinib. That's why
I think you're right. I believe it was ESMO. That was sometime in the fall. Yes, that's correct.
I was also on the board at the time, so that's why I remember it so well. And okay, standing ovations is a bit Hollywood, but it was kind of predictable. We hadn't expected this level of therapy control. All of these are superior in terms of progression-free survival. This is not an overall survival advantage. And the prediction was that after another 2 years, so after 7 years, that we would still have similarly good data as we did 2 years ago. And that's actually nothing more to it. We just checked whether after 2 more years, making it 7 years, we still have similarly good data as we did after 5 years. And that is what we found, was shown here. And I'll just skip over that because this curve is simply incredible. So you see, this is crizotinib. Crizotinib is better than chemotherapy. You also see that among patients on crizotinib, after 7 years, 3% still have control over the disease. But with lorlatinib, it's almost 55%. And the drop from 60 to 55 in 2 years, so that actually only accounts for a total of 5%. And the vast majority of those cases are not even due to lorlatinib failure, or were affected due to other disease-related reasons, which is why they didn't continue the treatment. Sometimes it was even due to an accident or something similar. So these are truly impressive data. This means we have such good disease control with lorlatinib that we really have no choice but to make it the absolute standard now. Everything else is significantly worse. And side effects, yes, whatever, you just have to get through them, but not because of the medication side effects. Rather, you can reduce the dose so that in the end, it's actually not that poorly tolerated. But you really have to balance it individually to some extent. When do I do it? When do I not do it? Can I increase the dose again? Probably not, and so on and so forth. But you do see in many patients an incredibly long period of disease control. And that's fantastic. But it has already sparked 2 new discussions. So we probably won't see any overall survival data from the study, because by the time that happens, another 10 years will have passed. And by then, no one will be interested anymore. I've already talked about side effect management, but there are 2 other topics that are important. The first is right at the beginning here. There are indeed a few patients who obviously do not benefit as much because the curve does drop quite quickly here. Which patients are those? And here it truly depends on whether there are distinct differences within this ALK group. So with which method was the testing done? Could that be confirmed? Is it NGS-based or PCR-based? Is it immunohistochemistry? Obviously, not all of these are the same. Secondly, there are additional mutations and so on. Would it help here perhaps to combine it with chemo? But of course, we don't know that. This is where the term ctDNA might come into play. And the substance has great brain efficacy. Patients with 55% progression-free survival after 7 years stay stable instead of needing early radiation is probably complete nonsense, because they mainly suffer disadvantages from the side effects and gain no benefits. So you can see how relative all of this is. And that's actually the second topic. How are we really talking about the group of patients whose disease is still under complete control after 7 years, where the decline per year is just about 2 or maybe 3% at most? That means these people have a virtually normal life, except for the side effects of lorlatinib therapy. How exactly are these specific patients managed? Are they treated with the identical standard of medical care? For example, if a heart issue arises or something similar, or do people say, well, when facing stage 4 lung cancer, you have to ask yourself, what do you want to do? We need to examine the whole picture of lung cancer, especially the ILK variety. It is not exactly about just putting it into perspective, but rather we have to look at it much more closely and look at it from a different perspective, depending on the individual course, on the individual tumor, and what options the individual tumor can offer us. Not every group of mutations has this great course, as we are now experiencing here with lorlatinib. And even there, new medications are being developed with, in part, a better side effect profile. And whether they will be just as effective as lorlatinib, we don't know, of course, because the studies are not yet underway, and how long these studies will then take until they are conducted, given such good efficacy. So you see, this is also where we reach the limits of research, because how long do you want to conduct studies? If I have a new medication today that is supposed to be better than lorlatinib, it might take me 10 years to find that out. By then, my patent is almost expired, so it's all difficult. So there are interesting new problems that we get to discuss. Great curve.
Well, to be perfectly honest, to call survival a problem is something that would not even begin to occur to me in this context. Of course, as you have already quite clearly mentioned at the very beginning of our discussion, the question is, what would a comparison with a second-generation TKI have looked like, namely with alectinib? I can also personally report 5 years of progression-free survival with it. And of course, the side effect profile is different again, and you mentioned that as well. That's another point you brought up. That was also an interesting aspect of the study, namely that the long-term effect apparently was not influenced by dose reduction. And that raises the question for me, what does that mean for everyday clinical practice? Can this be taken into account in the initial dosing in the future? Because many patients do have considerable concerns about these side effects caused by lorlatinib.
This is a tablet dose, which means everyone gets the same dose, regardless of whether they're big or small. And every person metabolizes these medications also a bit differently. So it wouldn't necessarily go down right from the start. That is not something I would do. That's also not how this study was conducted. But if side effects occur, one can and should consider a dose reduction. That doesn't mean that you have to reduce the dose immediately with every side effect. For example, increases in cholesterol and so on. But if you do reduce the dose because you have to, it is not disadvantageous. And you do not necessarily require alectinib as a comparison arm for this data, because this question is now well established and settled. Of course, that doesn't mean that all patients now have to be immediately transitioned to lorlatinib, because that hasn't been studied either. And of course, there are currently no studies that have investigated this. And we would also generally not do that. If a patient is doing well long-term on alectinib, then it shows that this tumor can also be well treated with alectinib. Even with crizotinib, it was still 3% after 7 years. And we would just let that continue for now. Of course, you can always switch to lorlatinib later on. The question is whether the tumor will then be a different one than if you had treated it with lorlatinib right from the start. Probably yes. But even there, although we do learn from the lab, if things have gone very well with alectinib so far, we wouldn't say, oh God, wrong medication, we have to switch to lorlatinib now. We wouldn't do that right away.
However, that actually served as a good segue to the next study because there are several factors to consider. Patients, as you already mentioned, who either did not benefit or did not benefit for long, and for those patients for whom this applies, who experienced progression under lorlatinib. The next study that is of significant interest is namely the ALCOVE-1 study. This clinical trial focuses its primary attention on patients with advanced or metastatic ALK-positive non-small cell lung cancer, including those specific cases with the ALKG1202R mutation, which is widely known to be a significant resistance mutation. In this clinical study, a promising new drug is currently being tested in this context, namely neladalkib, and researchers closely observed two distinct patient groups, those who were pre-treated with TKIs and those who were TKI naive, which signifies that they had not yet received a tyrosine kinase inhibitor.
Exactly. There was just some initial data on this medication. It's one of several being developed for ALK. And this specifically G1202R is a resistance mutation, one of the rare group of mutations that even have a chance to develop under these potent TKIs. So it is just one of the few mutations that can actually occur. Usually when the tumor progresses, it actually has nothing to do with ALK anymore because ALK is inhibited so perfectly. And yet there are still slight possibilities for improvement. And that's what was thoroughly examined right here. The two cohorts have already been discussed in some detail. And here the focus was mainly on response, including response in the brain. And yes, so you can see that these pretreated patients actually responded quite well. Also responded here, 78%. Of those, 91% had also been pretreated with lorlatinib. So that's great. Even in this resistance situation, there were people who responded, although significantly fewer. And there was also a response in the brain, so a great substance. When you stop to think about it, you can potentially utilize this option if you progress while on lorlatinib. But of course, this is not yet an approved substance. However, the study involved 253 patients in all kinds of clinical scenarios. A great option to have after lorlatinib, because that's actually already, and the first choice if you progress on another TKI. And if the patient is therapy naive, meaning hasn't received any treatment yet, then, of course, the patient has a significantly higher response rate, 86% response duration, and 91% after 12 months. Also a very good probability of response in the brain, but that's only 44 patients. And if you now ask, well, is this better than lorlatinib? Then you can say, I don't know, you need larger patient numbers for that. But you can already see with lorlatinib, the bar is set very, very high. And you'll have to really stretch yourself quite far to reach that. It was certainly very encouraging to see that the overall tolerability seems to have been better. ALK is inhibited much more selectively than with lorlatinib, which also affects other receptors a bit more broadly as well. And here the drug was developed in such a way that other receptors are spared as much as possible. There was already some discussion that, well, maybe that's also why the effect in the brain might not be quite as pronounced as with lorlatinib. So it may be that one day we will also differentiate which substance we use based on the pattern of metastasis, which substance we use. So there is hope. But we do not quite understand what it means just yet. But it is nice that we are getting these new substances, and I really wish I could use them.
Yes, I have to say, to be honest, that was really very surprising to me as well, that after the Crown study, so this was probably all set up and initiated earlier, but that anyone would even dare to take on anything at all, to conduct studies in the field of ALK, because it's really difficult to get access to lorlatinib in this area.
If the substance is every bit as effective but has better tolerability, new standards are established immediately. Exactly.
That is the great hope for us patients, that there will be something with a different side effect profile, or with the most minimal a side effect profile as possible. That just enables us as clinicians to look forward with much greater confidence to the future, even for patients who go through all the treatments and do not remain stable for long on lorlatinib, because unfortunately there are still patients like that despite the results. Yes, we also briefly talked about another study, specifically focusing on the specialized field of targeted medical therapies, but we were not quite ready to present it at this time because everything is just far too new at the moment right now. Recruitment for this study is currently underway. It's about HER2 positive patients and zongertinib as adjuvant therapy versus standard therapy. This is the Beamion LUNG-3 study.
No. That's going to take a little longer. So the substance is really exciting. We've already used zongertinib here as well. HER2, a more effective TKI. Again, such a rare mutation where fortunately further developments are still taking place. And this medication is indeed very, very promising. But with adjuvant studies, we'll have to wait several more years. The study is ongoing. There's nothing to say yet. There is still no data on it. It is definitely hopeful. But for now, for me, it applies primarily to patients with metastatic lung cancer. We've already used it there as well, but it is not yet approved in Germany. That can only be attempted through health insurance applications in the end. And yes, study participation, very important study participation.
Participation in the study as an outlook. Recruitment is already underway at 5 sites in Germany, and more will be added. So for patients with this very rare mutation, this is definitely a ray of hope that we didn't want to withhold. Yes, that is correct. Then we've now comprehensively covered the targeted therapies as well. I would like to take a moment to sincerely thank you for your very detailed explanations and for the exceptionally good conversation we had about various aspects of the therapies today and their profound significance for daily clinical practice and routines. And yes, I will now say goodbye to you and thank you once again for your time. Also on behalf of all patients,